Good evening, friends, and a very happy and healthy new year to you and your family members and your patients. This time, I thought normally on a milestone webinar, I call experts, but this time I said I have missed few webinars, so let me only take it. Dr. Aarti, your comment is very apt, but this webinar has been triggered by the experience of a doctor. I will not take her name because I am not at liberty. Her 43-year-old brother died due to a sudden heart attack. He was on hypertensive for 2 years, checking BP regularly, and BP was normal. And all of us will agree that these sudden heart attacks or sudden cardiac arrests, where we do not know what is the cause, because we all know that when we fill a death certificate, writing a cardiopulmonary arrest is easily accepted by the authorities, and none of us would want to refer for a post-mortem, which ideally should be. So I said, let me touch upon, because preventing a sudden death in young or in elderly is our responsibility, because we see patients regularly. We don't see them once in 2 months, 3 months, and for 2 minutes, our patients listen to us. So we have to take a call. Which patients am I going to start getting suspicious? I always remember a line given by Dr. Y.K. Amdekar, the renowned pediatrician, which is like, for me, a line on earth or stone. Every time you send a child out of your clinic, ask yourself, is this child going to die in next 24 hours? And only when the answer is no, you send the child out. I always think the same thing for every patient, young or old. And then we have to pick up cases which we are not certain. We don't want to be certain ever, because a good clinician also can be called a panoply doctor, that all his predictions come true. But we have to suspect and we have to prevent a sudden death. Sudden death in the young is rare. I would say was rare, but now it's getting more common. All of us present here, currently around 120 doctors, we all have seen in our practice or our relations. About 25% of cases occur during sports or marathons, or people who are supposed to be fit. The founder of Herbalife, the founder of Epigemia Curd, a fitness enthusiast, a gynecologist in Bombay practicing for his marathon, collapsed. 25% of sudden deaths are in sports, football, or marathons, or practicing for marathons. And nowadays, we have seen certain deaths in gyms also. Most young people with sudden cardiac death have underlying heart disease with either hypertrophic cardiomyopathy and or coronary anomalies, which are the most common causes. Like out of all sudden cardiac deaths, 72 to 77% are cardiac origin, rest are others. What's the incidence? The most common cause of sudden cardiac death is coronary artery disease. Why it is silent? Because we know that a coronary artery blockage of left main up to 90% will remain asymptomatic if the person is doing only accustomed exertion. So who's this accustomed exertion? A CEO of a company, a very senior executive who has no time for exercise. His driver picks up his laptop bag and his tiffin, and he comes down, car is waiting, he sits in the car, goes to office, gets in a lift, goes to office again, come back home like this. Zero physical activity. Till 90-94% his left main blockage will be silent because he's not done any unaccustomed exertion. And this person can suddenly collapse one day during a meeting due to stress. Cardiac arrhythmia most often causes sudden cardiac death in people younger than 35 because they are into fitness and they are into marathons. Arrhythmia is a death which you can suspect it was arrhythmia because these people do not have time to even reach the hospital or even complain that, oh, I have pain. These cases, if a postmortem is done, the postmortem will not show a pale patch on left ventricle showing that this part of the heart has infarcted. Congenital heart issues or genetic conditions that affect heart's electrical system cause arrhythmia, and congenital conditions at times can cause sudden death also, as we see ahead. Common conditions, coronary artery disease, as I already said. Arrhythmias, again heart related. I would say malignant arrhythmias, ventricular fibrillation, ventricular flutter. Cardiomyopathy, either dilated cardiomyopathy or hypertrophic obstructive cardiomyopathy. Long QT syndrome. Those of you who can read a ECG, long QT syndrome is a risk factor for malignant tachyarrhythmias. Although there are many causes for the prolonged QT, patients with prolonged QT are at a risk of malignant ventricular arrhythmias, syncope, and sudden death. Here again, it could be coronary artery disease or whatever, but then prolonged QT above 0.44 calculated is a risk factor for malignant ventricular arrhythmia, tachycardia or fibrillation. Myocarditis. The commonest deaths, cardiac deaths that occurred in COVID were COVID-induced myocarditis. Diabetes mellitus. Diabetes mellitus is a common cause for sudden cardiac death because the oxidation and the chronic inflammation that diabetes causes in our system leads to sudden cardiac death. And we know that all the risk of complications of diabetes are also seen in pre-diabetics. Pre-diabetics, it's not that diabetes says, okay, if you're pre-diabetic, I will leave you alone. No, sorry. They have the same risk of complication. Cerebrovascular accidents, strokes, aneurysms, AV malformations, pulmonary embolism. A lot of DVTs go undiagnosed And one fine day, the person has collapsed. And he may have said chest pain, and then he'll be labeled as a heart attack. Congenital aneurysms in the brain, aneurysms in the aorta, arteriovenous malformation, and Eisenmenger syndrome. Eisenmenger syndrome is reversal of shunt. Many times we have patients who have congenital heart disease, and we know, and they say, oh, doctor, I have it for 30 years and I'm fine. And we believe they're fine. But all these patients are at a risk of sudden cardiac death. So let me spend some time on Eisenmenger syndrome. Is defined as the process in which a long-standing left to right cardiac shunt. Left to right cardiac shunt, that means oxygenated blood is mixing with deoxygenated blood due to a congenital defect like ventricular septal defect, atrial septal defect, and very rarely patent ductus arteriosus, leads to pulmonary hypertension, and eventually the shunt reverses. Deoxygenated blood enters the left side of the heart and goes to the peripheral circulation. This patient can die. This patient can die on the spot. And Eisenmenger syndrome or reversal of shunt in pregnancy or during delivery is virtually fatal. So if you are looking after antenatal care of your pregnant patient, make sure she undergoes a 2D echo at least before her first delivery. Who is more at risk? Common cardiovascular and cerebrovascular diseases. Hypertension. People with hypertension or pre-hypertension are at risk. If you take home nothing today, take home one message: there is no borderline hypertension, there is no borderline diabetes. And always say that people who live at the border are more at a risk of death. Diabetes mellitus, pre-diabetes, and even insulin-resistant patient. Because insulin-resistant patients have a combination of metabolic problems, which we'll be discussing today in detail. Dyslipidemia and atherosclerosis. I had high cholesterol, doctor, but now it is normal. We have to tell them that what is normal is what is seen in your bloodstream. Nobody knows how much is deposited in your coronary arteries or carotid arteries or renal arteries. Morbid obesity, and you and me know today obesity is increasing, more so in children. Smoking, excessive alcohol consumption. Small amount of alcohol, 30 ml, 5 times a week, may actually open up coronary circulation, but nobody listens to that. You may tell the patient that he will step out of your clinic, he will forget 30 ml, he will say, doctor allowed alcohol 5 days a week. Significant family history. We know MI or stroke in father below 50 and in mother below 55 is a risk factor for the patient, father or other sibling. Unscientific sports behavior. I have been told you are overweight, you're putting on weight. I stand on the machine today, I am 96. I am just 170 centimeters. I am 26 kilos overweight. I go and buy nice tracks, nice shoes, nice gym bag, and I go to the gym and I appoint a trainer, and the trainer says, sir, you are too good, you are doing it. I push myself. Before going to the gym, I have not tested for hypertension, diabetes, ECG, nothing. And I do excessive activity. People, like yesterday, a child came to me. Child means he's 21-year-old. Doctor, I went to the gym and I lifted weights and I felt funny in my chest. How much did you lift? Mild weight. How much mild? 70 kilos. I said, 70 kilos is not mild, but I used to do it before. I said, before means how much gap? No, for 6 months I have not done. Then he has to start slowly. Starting again with 70 is unscientific sports behavior. And friends, when you ask history, you have to ask detailed questions. I am used to doing 670 kilos, but has there been a gap or no? Those with poor disease control are at a higher risk. I remember a doctor, I'm not going to name him with due respect to him. He was a very renowned doctor. His clinic had 10 assistants. And he would tell me, Dr. Asrani, 240 sugar is normal for me. I told him, what are you talking? The guidelines don't depend on how great you are. And he died at the age of 58 in COVID. So people, all these people, you have a patient of diabetes with 20-year reports of all normal. FBS, PPBS, HbA1c, all normal. That is the patient who's at a risk of sudden heart disease. And if the disease control is poor, then they are at a bigger risk. Then there are people say, I have diabetes, but I'm not on treatment. So that doesn't absolve you from the risk of sudden cardiac death. Even pre-diabetics and those with pre-hypertension are at equal risk. That brings us to syndrome X. अरे उसको तो कुछ भी नहीं था, वो मर गया. त्याला काहीच नव्हतं, एमने काही नाही હતું. But he had pre-hypertension, he had pre-diabetes, he was obese with android obesity. He was a candidate of sudden cardiac death. That is why syndrome X was devised in 1990. The X in syndrome X was used to emphasize the fact that importance of insulin resistance as a coronary heart disease risk was relatively unknown in early 90s. Why this patient died? Because he was insulin resistant. Syndrome X, as outlined in its original version, suggested that insulin resistant non-diabetic individual, this person has a HbA1c of 4.9, would be at an increased risk to be somewhat glucose intolerant, dyslipidemic with a high TG, low HDL, and hypertension, so-called borderline hypertension, not hypertension. No doctor will ever tell him take medicine. Since 90s, the number of abnormalities shown to be associated with insulin resistance or syndrome X have expanded. So when insulin resistance, what is insulin resistant? Let me explain in simpler terms. I eat a meal. That meal requires 80 units to digest and keep my sugar levels normal. My PP comes to 130 in 2 hours with 80 units insulin that my body secretes. Now, I have insulin resistance. I have android obesity. I have acanthosis nigricans behind my neck. I have a family history of diabetes, but my mother got diabetes at 55. I am today 40 only. My insulin has become defective. So although my body is secreting 80 units, the efficacy is only 40. Then my body has to secrete more insulin. So insulin resistance leads to more insulin secretion, or what is known as a compensatory hyperinsulinemia. So what are these other abnormalities? Let's see. Impaired fasting plasma glucose concentration. So from 100 to 125. Impaired glucose tolerance, PP, about 200 post-lunch. Uric acid, plasma uric acid concentration high. Renal uric acid low. We never check renal uric acid, but plasma is high. Dyslipidemia. Insulin resistance dyslipidemia is largely affecting plasma renal triglycerides and HDL. Triglyceride is high, HDL is low. Postprandial lipemia. We never check this. After meal, the lipids go high and LDL particle concentration is reduced. Hemodynamic, renal sodium retention, we never check. This affects the renal angiotensin system. Increase sympathetic nervous system activity. What is sympathetic nervous system? It causes our pulse rate to go up. It causes our BP to go up. It causes our sugar to go up and increase blood pressure. Procoagulant state, plasminogen activator inhibitor 1 increases, fibrinogen increases. So these patients, syndrome X, form clots faster, form good clots. A smoker also forms clots faster and good clots. Reproductive physiology is not involved in sudden cardiac death. But a polycystic ovarian syndrome patient is very likely to be diabetic and dyslipidemic. So again, you can follow that path, but I will not blame PCOD alone. So now we come to metabolic syndrome, or what is known as a insulin resistant syndrome or obesity dyslipidemia syndrome. The apple is the normal shape and the pear is the abnormal shape. Metabolic syndrome is a cluster of conditions that occur together, increasing one's risk of heart disease and type 2 diabetes, sudden death, that N is half hidden, so it is looking like R. Metabolic syndrome is the clinical term for what started earlier as syndrome X. These conditions include increased blood pressure, but not yet in the range that you have to write medicine. High blood sugar, but still pre-diabetes. Excess body fat around the waist, and abnormal cholesterol, low HDL, and or high triglycerides. At this stage, we are not talking of LDL alone. Let's see what are the statistics. If any one of you is thinking that what is Dr. Asrani talking, I don't have to worry about metabolic syndrome. Please look at this. Is increasingly common and up to 1/3 of US adults have it. And in India, incidence is 30%, and northern states it's 40 to 45%. Because in northern states, I have had patients come and tell me, sir, I am from Kanpur. In Kanpur, we can't go to sleep unless we have taken 150 to 200 grams of sweets every day. Diabetic or non-diabetic. If one has metabolic syndrome or any one of its components, we'll see what components we have to look for. Aggressive lifestyle changes can delay or even totally prevent the onset of diabetes mellitus and other complications. More and more people in India are becoming obese. Doctors here, please ask yourself how many of you have ideal body weight, which is height in centimeters minus 100 for men and height in centimeters minus 105 for women. And if you say answer is yes, I am ideal body weight, then is your abdominal girth more than your hips? If yes, then that's your android obesity. Insulin resistance has no symptoms. Sustained weight loss and exercise may help reverse insulin resistance. Why I have put may in capital and bold? Because sustained is a gold word. Most of the patients, when we ask of physical exercise, sir, I used to do regularly, that it's always in past tense. Those with insulin resistance typically have an imbalance in triglyceride HDL. I have repeated it multiple times so that you don't miss it out. We have been trained to look for LDL as a risk factor, but start looking at HDL and triglyceride as a metabolic syndrome denoter. Imbalance in triglycerides and HDL increase risk of heart disease. We know low HDL alone is a risk factor for coronary artery disease. High triglyceride alone is a risk factor for coronary artery. Little bit on what happens in IR so that you understand and you follow and save some of your patients. It will, if the insulin is effective, there is no resistance, then it will signal glucose absorption by muscle and fat. Body senses there is more blood sugar in the stream. It produces insulin. That insulin signals the pickup of glucose from muscle and fat. To compensate for this, the pancreas secretes much more insulin because now it is not triggering, it is defective. The pancreas feels this insulin is not enough to pick up the glucose that is in the bloodstream. So pancreas secretes more insulin, and what I explained earlier, insulin resistance leads to hyperinsulinemia. IR is hyperinsulinemia. Insulin resistance is equal to hyperinsulinemia. This is the sign you see in a fair lady, how dark is the skin behind. The biological response of fat, muscle, and liver to insulin is lowered because insulin is not effective. It may be there, it's not effective, resulting in appearance of risk factors clustered under the name of metabolic syndrome in one person. In fat cells, the breakdown of stored triglycerides, which elevates free fatty acids in the blood, and then you have high TG there. High TG causes HDL to go down. Clustering of insulin resistance, compensatory hyperinsulinemia, and dyslipidemia is the metabolic core of metabolic syndrome. So, three things: insulin resistance leading to hyperinsulinemia, leading to high triglycerides, low HDL. Syndrome X, metabolic syndrome, or insulin resistance syndrome. Insulin resistance, android obesity, hypertension, dyslipidemia. Dyslipidemia, particularly triglyceride and HDL. Glucose intolerance or type 2 diabetes mellitus, depending on what is the lifestyle of the person. Poor diet, inactivity, yes, otherwise android obesity would not have occurred only. Macroalbuminuria, if you check macroalbumin, it will be above 30. That means it's already affected the kidney. Macroalbuminuria is one test you do when a patient is first diagnosed of diabetes and every 6 months after that. Hyperinsulinemia, you may check insulin levels also. And hypercoagulability, a tendency to form clots. This, my friends, are the features of metabolic syndrome or syndrome X, or a collection of features which is leading to a sudden cardiac death in a person. So when people come to us, oh doc, how he died, you can't explain all this to them. It is a clustering of several insulin resistance associated cardiovascular risk factors. So go home with a message that insulin resistance is cardiovascular risk. Sooner or later. Obesity, central adiposity, increased sympathetic activity. So a person who may not be obese, who is very fit, but who has stress. What are stress hormones? Adrenaline, noradrenaline, leading to higher sympathetic activity, resting tachycardia, resting hypertension. Hypertriglyceridemia, low HDL. I have repeated at least 10 times so that you remember that the dyslipidemia here is not pure LDL, it is PG and low HDL. Abnormal glucose metabolism, either pre-diabetes or diabetes. Hyperinsulinemia, macroalbuminuria. If you see any good dietitian, when they take on an obesity patient, ask for insulin levels, they want to check is there hyperinsulinemia or not, and macroalbuminuria. Why I am saying macroalbuminuria is one of the cardiovascular risk factors. If you recall, presence of albumin in urine is indicative of renal dysfunction as well as coronary artery disease. Because diabetes, pre-diabetes or dyslipidemia is not partial to heart or brain. It affects all arteries, all small arteries, and Bowman's capsule has some of the tiniest arteries in the body. The clustering of risk factors results in a higher risk of diabetes and cardiovascular disease and maybe sudden death. That as compared to if the factor was single, it was not multiple. Occult coronary artery disease, sudden death as till 85%, but I have already explained till 95% can remain silent if the person has zero physical activity. What are the signs? One sign we have seen is acanthosis nigricans. Familial component, at least one first degree relative with type 2 diabetes. Obesity, BMI above 30. Central adiposity, waist to hip ratio more than 1 in men and more than 0.88 in women. Hypertension, a systolic pressure of 140 or more and a diastolic of 90 or more. So just read this line properly. Even 140 by 90 is considered hypertension. Stage 1. Or any patient with 120/70 but on antihypertensive drugs. Hypertriglyceridemia, TG above 150, HDL below 40 in men, below 50 in women. Abnormal glucose metabolism, either impaired fasting glucose or impaired post-lunch glucose as per the WHO criteria. FBS 110 milligram per DL, more than 110, and post-lunch about 200 milligram per DL are pre-diabetes. High uric acid, more than 7 in men and more than 5.5 in women. And you know, all these risk factors that we are talking now are silent. They don't give warning. You give a patient medicine for uric acid, But doctor, I have no joint pain. I don't have stones. Everybody's become clinically oriented now. So you have to convince them that this leads to other complications. Hyperinsulinemia. Fasting level is more than 13 mu per liter. Macroalbuminuria, more than 30 milligram day. It has to be tested on first sample of the morning, not second sample. And dear friends, by giving ACE inhibitors or angiotensin receptor blockers, this can be reverted to normal. These are the ATP3 criteria for metabolic syndrome. A diagnosis of metabolic syndrome is made when 3 or more of the risk determinants are present. Fasting blood glucose above 110, blood pressure above 135/85, serum triglycerides above 150, HDL below 40 or below 50, as we have said, abdominal obesity, waist circumference above 102 centimeter in men, above 88 in women. If you do not want to check waist and hip, you ask them, what is your trouser size? And you will come to know. And patient with sleep apnea. Central obesity is the most characteristic sign of MBS. Later on, I'll be showing a process, and there that is your first alert. MBS is very rarely seen in lean persons, only 2 to 4%. So you can say that android obesity, oh wow, metabolic syndrome. I am repeating diagnosis, although we have done enough times. History, anthropometric measurement, height and weight, BP measurement, and by assessing serum lipids, blood or plasma glucose 2 over GTT ppbs if fasting glucose is normal. You have other parameters present, fasting is normal, you do ppbs or GTT, or you do HbA1c. Uric acid should be estimated in patients with high blood pressure. You may omit otherwise. Uric acid, if remains high, all your attempts at controlling blood pressure will fail. So abdominal obesity, glucose intolerance, insulin resistance, hypertension, atherogenic dyslipidemia, that means high triglyceride, low HDL, pro-inflammatory, pro-thrombotic state, tendency to form clots, diabetes, and cerebrovascular or coronary artery disease. So what should be the process in your mind? You identify a patient of android obesity. Patient has come for cold cough, male or female. Your alert should go up. Ask certain questions. Look for acanthosis nigricans. If you see behind the neck is darker compared to the complexion of the person, then you know this patient is insulin resistant and hyperinsulinemia without checking insulin levels. Then you talk to the patient, convince them to you check up BP, ask for blood sugar, uric acid, and lipids. I'm not immediately doing macroalbuminuria. And then check for prediabetes. And then depending on the items present, the number of variables present, you diagnose metabolic syndrome. So this is the clinical identification of metabolic syndrome. Abdominal obesity, men above 102 centimeter or 40 inches, women above 35 inches. Triglycerides above 150, HDL below 40 or below 50, blood pressure above 130 and 85, and fasting glucose above 100. So 3 out of these is metabolic syndrome. What's the treatment? I'm sorry, we can't give drugs. Non-pharmacological treatment, increasing physical activity, systematic, regular Weight reduction. Quit smoking. Smoking is quit. Alcohol is moderation. And when you talk of weight reduction, don't tell the patient, vajan kam karke aao. No. I tell the patient, if you reduce 1 kg in a month, you lose 12 in a year. And losing up to 1.5 kilo in a month is possible without much ado. So you may lose 18 kilos in a year. Avoid drinking of alcohol more than 2 drinks per day. Change your eating habits, increasing the intake of fiber and decreasing that of fat, particularly saturated fat, and rapidly metabolized carbohydrates or highly refined carbohydrates. Important to motivate the patient and monitor the patient. It's not only motivation, monitor the patient to follow whether they are following it or not. I will spend some time on how MBS or pre-diabetes progresses to diabetes, or from a normal person, how does pre-diabetes, how does progression to MBS also occurs. So one thing I say that diabetes does not occur due to consumption of sweets. It is chronic overnutrition, and all of us are eating more than what we should. This is a person, you can see android obesity. These are 4 important organs: liver, pancreas, fat, and muscle. During overnutrition, patient gains weight. Fat cells progressively enlarge, and if the size becomes bigger, they are storing increased amount of triglyceride. And if they are storing increasing amount of triglycerides, blood levels are likely to go up. Excess fat intake in combination with increased release of fatty acid, triglycerides are coming out from the fatty tissue, accumulation of fatty acid in circulation, you have hypertriglyceridemia. Free fatty acids are released. These are eventually taken up by the muscle and liver tissue, which leads to insulin resistance in these tissues. These free fatty acids are taken up by liver, leading to fatty degeneration of liver, and in the muscle, and in both liver and muscle, insulin resistance. So when insulin resistance occurs, insulin cannot cause glucose uptake by muscle and liver. Liver stores glucose as glycogen. The beta cell compensate by secreting more insulin to maintain normal glucose level, and the patient is hyperinsulinemic. Patient does not stop chronic overnutrition. He keeps eating because everything is silent. And what can you tell a patient who knows that he's overweight? He knows he's eating wrong. He knows he's not exercising. Unless you give him some facts. If chronic overnutrition continues and liver triglycerides build up, eventually the capacity of the liver to store triglyceride exceeded. Liver cannot store triglycerides unending capacity. When this occurs, the liver produces increased level of triglyceride rich, very low density lipoprotein, VLDL. So VLDL is actually triglycerides plus LDL. So when VLDL goes to periphery, it's broken down into triglycerides and LDL. VLDL is TG and LDL cholesterol is increased, and this leads to low HDL cholesterol. This in turn leads to increased TG and LDL levels and reduced HDL cholesterol levels. Initially, the body compensates for this by producing more insulin, what we have been talking of compensatory hyperinsulinemia. And although in the early stages, there may be only a minor increase in the level of fasting glucose because the body is compensating. You know, a child not studying, mother does homework, child does better in the routine exams or the assessment. Then insulin resistance gradually worsens till a time when pancreas says, oh boy, I can't produce any more insulin. And then you get diabetes mellitus. See this. The first column is insulin production. Second column is fasting plasma glucose. And third column is insulin resistance. The black line indicates insulin efficacy or insulin resistance, sorry. The orange line is insulin levels and the red line is glucose. So in the initial normal phase, all three are normal. Then suddenly insulin resistance increases. Insulin is not effective. And this orange line going up is hyperinsulinemia. And because of this hyperinsulinemia, blood sugar still remains near normal because see, the insulin is almost trebled, but the sugar is still normal. And then the body says, sorry, boss, I can't give any more insulin. This is pre-diabetes. Same thing. And then insulin cannot be produced by liver. I mean, the pancreas, you see the insulin curve drops. Beta cells fail and the patient gets diabetes mellitus. This patient, in the journey that I have explained, I have never said consumption of excess sugar. I have never said consumption of excess carbohydrate. I have just said overnutrition. So friends, this is the way it generates the genesis of diabetes. Same thing. Next week, what are we going to discuss? Who and how to screen, BMI, blood sugar tests, hypertension, lipids, renal profile with macroalbuminuria. And in tests also, what to tell people, where to understand, how to counsel them. We'll discuss all of that. There are guidelines on which patient to check for sugar, even if there is no android obesity. But today I have tried to give you a guideline that any android obesity cannot be ignored. This patient may be the next patient who is going to be sudden cardiac death. So, Dr. Rajni Gwalani, okay, thank you, Rajni. Why different threshold for uric acid in male and female? Dr. Aarti, this is the way it is now even in the labs of NABL labs, no, there are two different levels they have given. Uric acid levels have come up for a change, and for males and females it is different. I actually do not know why, but this is as per NABL accredited labs. So I hope this talk has been useful to you in making sure that you do not face a sudden cardiac death in your family or in your patients. Thank you very much. Have a nice day. See you next week. Okay, one important announcement. In the month of March, we are going to have a face-to-face seminar, some lectures by me, Dr. Alka, and some renowned experts. And I have been talking of a platform disseminating knowledge that will be launched on that day. Our Indian Doctors platform will become a reality that day. So I'll let you know the date by next week so that you can block the date. And I promise it's not going to be exorbitantly expensive. Thank you very much. Okay, Dr. Ufriziran is asking if HbA1c is 5.9, should we start glycomate? No, make the person lose weight. You start glycomate, it will drop. Then he thinks, okay, I am fine now. I don't have to do anything. Only if the lifestyle management has not worked, you think of glycomate, otherwise no. HbA1c threshold now 8. I think we try to keep it up to 7. But in certain cases, I don't know. I keep 7 and I have not heard up to 8. So I am not sure. I'll check up and we'll discuss again next week. One thing is certain, that you should not try to bring it too low, because anything below 6 increases the risk of myocardial infarction. Methi seeds will not do the work. And if you as a doctor tell people no to take methi seeds, then they think it is equivalent to exercise and everything. I discourage all of these things. Methi seeds, lasun, 4 pieces. Thank you very much again. Bye.